Okay, well, welcome everyone. So glad that everyone is here to join us. Good afternoon, one and all. Excuse me, I'm hopeful that many of you were able to join the previous COVID-19 NHPCO webinar that was previous to this as well. Before we get started, just a couple of quick points and housekeeping things. I know that this being day 792 of being in quarantine, everyone is very familiar with Zoom, but just a reminder, please enter any questions, comments, anything that comes up in the chat box. Also feel free to use the Q&A. We are going to go through the presentations, and then following those, there will be some time for question answers. If you'd like to share a story or give some updates, there'll be time for that as well. Okay, so without further ado, I wanted to introduce our two presenters today. Excuse me. First joining us is Carol Lors. She is the director of the National VA Implementation Center and also the chief of hematology and oncology at the Brooklyn campus of the VA New York Harbor Healthcare System. Dr. Lors is an associate professor of clinical medicine at State University of New York Downstate Medical Center in Brooklyn, New York. She is also the director of the Implementation Center and has been since 2009. So Dr. Lors works with the Palliative and Hospice Care Program Office in the VA to oversee the VA Palliative Care Program development and also the mentoring of VA teams with the goal of developing high quality, sustainable palliative care programs at all VA facilities. She has also been a longtime champion of We Honor Veterans and a close collaborator with NHPCO. So we are very happy to have her here. Following Dr. Lors' presentation, we'll be joined by Candace Powell. She is the executive director of the Maine Hospice Council and the Center for End-of-Life Care. She's also a visiting professor with the Robert Gordon University in Aberdeen, Scotland. So Candace has over 40 years of professional experience working with end-of-life issues. She was previously the director of the Hospice of Lincoln County, and since 1992, she has been the executive director of the Maine Hospice Council and Center for End-of-Life Care in Augusta, Maine. She has been extremely instrumental in developing partnerships, including one of the original hospice veteran partnerships in her region, as well as the prison end-of-life program. So again, we are very thrilled to have Candace joining us. She serves as a mentor and more importantly, or not more importantly, but also in addition, she is also one of our trauma-informed care grant awardees. So we are thrilled to be working with her. All right, so without further ado, let's get started. And just a reminder, this will be recorded. It will be put up on the We Honor Veterans website. Also, there are some handouts and slides as well already available on the We Honor Veterans website. Go to the homepage, go to the trauma-informed care section, and they're up there right now. We will be happy to put the link to that page in the chat box right now. Okay, so without further ado, here is Carol.
Oh, thank you so much, Catherine. It's really a pleasure to be here. Catherine, could I just do a sound check with you? Can you hear me well?
Of course. Yep, perfect.
Okay, great. So thank you so much for inviting me. I'm really thrilled to be presenting today. And the title of the talk you can see is Strategies to Improve Family Satisfaction with Care of the End of Life for Veterans Who Die in VA Facilities. And I'll explain why this is such a complicated title and how it actually merges very nicely with the Trauma-Informed Care Initiative. Oh my goodness. Okay, thank you, Catherine. Before I just move on to my presentation, I did want to extend a congratulations to all of the state hospice organizations who have been funded in the Trauma-Informed Care Initiative. As you can see, there's 14 states involved in this initiative, and that brings us to about a third of the United States in this very exciting new initiative to improve the care of these patients. I also wanted to recognize the VA facilities that are involved in a similar initiative to deliver telemental health, and those are in Hudson Valley, New York, Pittsburgh, Cleveland, West Palm Beach, and Salisbury, North Carolina. And at least for 4 of those facilities, it overlaps very nicely with the hospices that are involved in the CARE initiative. Catherine, I'm not sure how to change the slides, so maybe you'll do it for me. Thank you. Now, just to take us back a little bit, this Trauma-Informed Care Initiative is actually the result of a needs survey that was done a while ago with the We Honor Veterans hospices. And what we found is that most hospices do ask about veteran status and about war era. Some, and it's a mixed sort of answer, some screen for PTSD, moral injury, and suicide intent. But we found that the majority of hospices do not have the capacity to treat these mental health issues and also to address these areas of concern. And so many of the hospices in answering this survey saw a great value in VA providing telehealth to meet this need. And so the result is the Trauma-Informed Care Initiative. So next slide, please. Thank you. So the Trauma-Informed Care Initiative is actually funded by Congress to improve the care of veterans on hospice that have been impacted by trauma. And a couple of years ago, the focus was mostly on Vietnam-era veterans. And then the recognition came that trauma-informed care is important for all veterans, and I'm sure a lot of non-veterans as well. And so the focus of this has been expanded. So our goals for this initiative is to expand access to VA palliative mental health expertise for veterans on hospice that are in their homes, to share the VA expertise via the National PTSD Consultation Program, and during the Q&A we can talk about that a little bit. And lastly, to train community hospice staff to provide care in this area for veterans impacted by trauma. Next slide. So what I wanted to present today is our overall approach in improving the quality of end-of-life care for veterans. Now, each of our VA facilities, there's 142 of them, each is a little bit different. They differ in the services they provide, they differ in how many beds they have, and they differ in what kind of venues of care are available. And we know very much that the kind of care that's delivered or the kind of experience that veterans and families have in acute care and ICU is very different from the kind of experience they may have in our community living centers, which are our VA nursing homes. And most of our hospice units are in our community living centers, so we find the experience to be very different based on venue of care. Now, what I'd like to do is show you how we use this quality improvement approach and how we might then transition it to try to improve end-of-life care of veterans who have been impacted by trauma. And lastly, I'd like to discuss and also offer our practice guides that we've developed, both for emotional support prior to death and for post-traumatic stress disorder. And I'll be discussing those a little bit. So the next slide shows our key performance indicators for palliative and hospice care in VA. And you can see that there's 3 of them. The first is the patient and family experience, which I'll come back to in a moment. The second is access. Now, we have improved access to inpatient hospice and palliative care in most of our VA facilities. And so for the past few years, we've really been focusing on growth in outpatient palliative care. And what you see on the right-hand side of this slide is in 2019, over 50,000 outpatient palliative care consults were done in our facilities. And we're focusing on trying to improve that access and improve access to earlier and earlier palliative care for patients with serious illness. And lastly, also very important, is our partnership with you. And the number of community hospices in We Honor Veterans at this time that I made this slide was 4,058, which is just a phenomenal number of hospices that we've been partnering with to improve the care of veterans. Would you hit the slide again? Thank you. So I want to go back to the bereaved family survey because this is by far our most important measure. It's what we refer to as our quality measure. And what I'm showing you here is the percentage of families who rate the care in the last 30 days of life as either excellent or very good. And it's actually in 2019, it was 88% of families. And I say that with a lot of pride. You can see that back in 2016, 84% of families said that the care in the last month of life was excellent or very good. And we've actually improved consistently on this measure over the years. And the next slide shows that graphically. If we look back in 2010, 81% of families were reporting the care as excellent or very good in the last month of life. And as we've moved forward in the years, up to 2019, we have 88% of families reporting the care as excellent or very good. And the improvement is the result of very hard work on the part of our palliative care teams and also on the part of other staff that works in our hospitals. So to support these efforts, we've developed a national quality improvement collaborative process, and that's on the next slide. So this process is supported by our program office, and we meet with the palliative care teams in each VISN, and there's 18 VISNs. We meet with each of them twice per year. And in that call, what we try to do is engage in a dialogue with our palliative care teams. We review their metrics that we see. Oh, I see someone said the sound is interrupted. Is the sound better now?
Oh yeah, you're a lot more clear. And let us know, it sounds okay on our end, but if anyone else is having trouble, yeah, please enter it in the chat box. But you sound good, Carol.
Okay, great. Yes, thanks for letting me know.
Uh-huh.
So I wanted to walk you through, just go back one slide, please. So what we try to do in our quality collaborative goals is engage our teams in a dialogue. We review their metrics. We try to make sure that what we're seeing on a national level is what they're seeing at the facility level. We share what we think would be a good focus for quality improvement. And in this example I'm going to show you shortly, I'll show you a focus on the bereaved family survey. So we look at where we think facilities might want to improve, and then together we discuss what kind of interventions might be most feasible and actionable in that particular facility. And then we provide them with resources. We use peer mentoring. We have an analytic process called decision trees that I will show you in a moment. We have a compendium of best practices that have been contributed by our high-performing facilities, and we also have brief practice guides that we recently developed and that I'd like to share with you. So on the next slide, I'm going to give an example of how we might walk through a quality collaborative process. So in VISN X, there's a very wide variation in these facility bereaved family survey scores. We can see that some facilities in this VISN are doing very well and scoring over the national average of 64%, but we also see that there are some facilities that are doing quite poorly. And you see the facility over on the left-hand side, only 35% of families in that facility are rating the care as excellent in the last month of life. So we want to help these facilities in quality improvement. So if we drill down just a little bit, on the next slide, what we're seeing here is individual venues of care. So the venue of care of intensive care or acute care is shown in blue. and the venue of care of the community living center or VA nursing home or hospice units is shown in red. And you can see that the national average for the hospice units and the community living centers is about 70%. Acute care and ICU has always been lower, and that's running as a national average about 56%. And once again, you see this very wide variation among the different facilities in how they're performing on the bereaved family survey. So let us focus on one facility. And would you hit it again, Catherine? Let's focus on Facility C. In Facility C, we have, just hit it once again, Catherine.
Let's see. There we go.
Thank you. So what we can see in Facility C with the drill down, we see that they're above the national average in the community living center, but their real area of that might be problematic is in acute care and ICU. Now, if we look across the vision and hit it again, Catherine. If we look across the vision, we see a facility, Facility H, which is doing very well. And so hit it again, Catherine. So we can say, well, all of the facilities in a vision have some sort of a relationship with each other. So we can sort of set up some peer mentoring for Facility H to serve as a mentor to Facility C. But what should this team focus on? Where can they get the biggest impact with an intervention? Move it forward again, Catherine. So how can they focus their QI efforts? If we look at the bereaved family survey, there are 16 different questions, and each one of them deals with a different aspect of care. Did the staff take time to listen? Did they provide medical treatment? Were they kind, caring, and respectful? Did they keep you informed? Were personal care needs met? And the next slide shows the rest of the questions on the survey: spiritual support, emotional support both before and after death, and benefits. So the big question for Facility C is, where can they focus their efforts? Because if they try to do everything at once, it's very unlikely that they'll be successful. So what the Veteran Experience Center has done, and you can advance it again, Catherine. What the Veteran Experience Center has done is a very sophisticated statistical analysis using machine learning techniques, and this is called decision trees. And what the decision tree analysis permits us to do is to identify the one question on the bereaved family survey that has the greatest potential to improve the family's perception of care at the end of life. And then these questions are reported out during our quality collaborative calls as what we refer to as the pathway to excellence. And so on the next slide, we can see for this particular vision, these are the results of the decision tree analysis. And if we want to focus just on Facility C, and Catherine, you could advance it again. If we focus on Facility C, what's recommended by this analysis is that they put all of their efforts on emotional support prior to death in the acute care and ICU venue. So if we move forward another slide, the question is, how can we help them? So we have two tools now that we've combined into a single brief practice guide that we want to share with you. The first tool that we have is our compendium of best practices for the bereaved family survey. Now, in order to develop this compendium, we interviewed 5 or 6 of the top performing VA facilities for each question on the bereaved family survey. So our top performers for every single question. And what we did was we interviewed many different types of facilities. Facilities that were predominantly community living centers, some facilities that were our bigger acute care hospitals, and we summarized the best practices for each of these 5 facilities. And also we provided contact information in case the facility that was working with the compendium entry wanted some additional details or maybe some friendly mentoring. Now, in addition to the compendium And what our palliative care teams recommend is what's seen on this slide, and that is what families have valued. So what one of our centers has done is taken an analysis of 1,500 responses to our open-ended questions on the bereaved family survey. And these two questions are, is there anything else you'd like to share about the patient's care during the last month of life? And is there anything else that you'd like to share about how care could have been improved? So they took all of these responses, categorized them into domains of care, and then linked them to individual bereaved family survey questions. And so what we have here is what palliative care teams would recommend and also what families have valued. And we've put those together into our brief practice guides. And that you'll see a sample on the next slide. So this is the brief practice guide for emotional support prior to death. And what we have in bold under bereaved families have valued is what families have told us were most important to them. And so, for example, offering a physical presence, holding the patient's hand, having someone sit overnight with the veteran at the end of life, or involving volunteers to sit with veterans at the end of life. And then underneath that, we have what palliative care teams have recommended. Having a vigil team available 24/7, having staff remain present in the room to provide emotional support to families at the time of the veteran's death. Now notice how similar those are. And so combining them into the brief practice guides, which are simple one-page documents that includes both what palliative care teams recommend and what our families have told us. So we're finding these to be quite helpful to teams to go back to their teams, go back to their staff, and say, which one of these things could we implement at our facility? But now we have a new challenge, and on the next slide we see what that challenge is. We have an increasing number of veterans who served in Vietnam or during the Vietnam War, and they're dying now at a greater rate than any of our other World War II or Korean War veterans. And what we've learned about these Vietnam-era veterans is that they have a number of mental health issues. And on the next slide, I'm showing a slide that was previously presented on a webinar, on an NHPCO webinar by N-Cut Lee and Shimrit Kedem. And these are the most common mental health or substance abuse conditions that we find in the VA system. And what they did is they looked at a comparison between Vietnam War era veterans and World War II post-Korean War veterans. And what they found is for each of these mental health and substance abuse conditions, there was a statistically higher number of Vietnam War era veterans with these issues than World War II or Korean War veterans. And that includes depression, anxiety, alcohol use, post-traumatic stress disorder, other mental health disorders, and substance abuse. So we have a challenge in front of us that we need to face. And so what we've done is done a decision tree analysis on a national level for Vietnam veterans with PTSD that are in hospice. So we took a national look at these veterans to see what might be the most important area of care that we could render these patients. So we see what their baseline scores are on a national level, and that is that 60% of Vietnam veterans with of the families, I should say, of Vietnam veterans with PTSD in hospice rate the care as excellent in the last month of life. And that's lower than our national average of 64%. Now, if we break that down with our decision tree analysis, and you can move it forward one, if emotional support is always provided prior to death, we can improve that care at the end of life to 80% excellent. If, on the other hand, emotional support is not always provided prior to death, we see that 73% of these families will say the care is not excellent. And so that excellent rating falls down to 26%. So that is such a critically important area for us to focus with these patients that are in hospice with PTSD. Now, if we go back again and we look at what else is important, we can see that if the staff always took time to listen, in addition to providing emotional support prior to death, we see that 85% of families will rate the care as excellent. So the takeaway from this decision tree analysis is that always providing emotional support prior to death will improve the family's perception of excellent care. And then to have an even greater impact, always taking time to listen to the veteran and family will improve the care even further. And so what I'm presenting now is the decision tree, the brief clinical practice guide for post-traumatic stress disorder. I've only given you a little bit of a snapshot. I believe Catherine has posted the entire practice guide for you to look at, and hopefully you'll take a look at it and let us know what you think, because this is an iterative process. We want to learn from you as we learn from our teams. And so what we see in this brief practice guide, bereaved families have valued that monitor the veteran's response to potential environmental triggers, pictures of combat scenes, other veterans chatting about military service, and modify the environment accordingly. And then what palliative care teams recommend: screening for PTSD on admission, give the staff training on PTSD and make sure that they're knowledgeable about triggers, and then the team getting family input on tips on how to provide better care for the veteran. So I'm hoping during our Q&A we can discuss these brief practice guides and hear from you what you think might be most valuable. So I want to thank you all very much.
Well, thank you so much, Carol. And again, keep those questions coming in. We're taking note of them, and we will be having a Q&A and discussion session at the end following Candace Powell's presentation. So now, without further ado, I am going to hand the controls over to Candace. Candace, let me know if you're able to click through.
All right. Be patient with me.
We're not going anywhere.
My trusty, wonderful executive assistant is navigating this. So. Thank the good Lord. And while I'm waiting, I just want to give a shout out to everyone and say I'm delighted to be with you all. And I certainly hope that you are all safe and healthy during these challenging times.
Yeah, so could you just click the...
I've got it, my dear. I'm all set.
Okay. Oh.
All right. Well, maybe not. It keeps showing up and then disappearing.
I think all you're going to do is,
Yeah.
Isn't it page down?
Page down and page up arrow, Catherine?
Yeah, or try left or right.
Oh, I have a choice.
We'll see what works.
Neither one's working.
None of them do. There we go. All right, thank you. Thank you.
Sure. Mm-hmm.
Yeah, so I have the privilege and honor of joining Carol and Scott and Catherine and all of you wonderful folks out there. And, oh, somebody's having trouble with the sound.
Yeah, you're coming in Loud and clear for most of us. I know that a couple of people are having some listening issues, and yeah, just want to quickly remind folks, sometimes it comes in a little bit better if you do dial in from your phone rather than using your computer speakers. But yes, worst case scenario, this is absolutely being recorded and it will be up on the We Honor Veterans website, so you could re-listen to it again.
All right, so my voice is audible for some of you, but not for others. I'll speak as loudly as I can. Thank you. So I have, again, the privilege of joining all of you, but my presentation is going to be quite a 45-degree departure from Carol's. And I asked Carol if she'd go first because her data was comprehensive and just wonderful data. But I'd like to drill it down a little bit for everyone and get to the people behind the data. And not only that, my intention is to help you understand that PTSD is so prevalent for our general population in the United States and actually all over the world. Some data, some statistics say that between 55 and 95% of all people in the general population have some kind of trauma in their history. And it goes undetected, unaddressed often. So because the Maine Hospice Council, and that's why I put this first slide up for you, for those that aren't familiar with our work, we have chosen over the years to do a lot of work with underserved and disenfranchised populations. And we do it in collaboration with other partners. And I'm not going to dwell on this, but I do want to add that all of our programs intersect with one another. They do not silo themselves just because they're discrete populations that we might be dealing with a particular grant or a particular initiative. And we started a prison hospice program here in Maine with our only state prison, the Maine state prison, back in 2000. And in 2004, we started a hospice veteran partnership, not solely because of the work I was doing at the prison, of course, but because the prison population is quite populated with veterans. And I have another slide later on that I'll explain more in detail and explain a conversation I had with Dr. Shreve. So those two intersected so smoothly and so nicely with each other. But Carol's data, I do want to tell you, it's wonderful for the community, but to get permission within the prison to be able to do a family survey is impossible. And you might say, well, families aren't in the prison with patients when they're dying. And I'll talk a bit more about that as well. Would you advance the slide, Catherine, for me, please? So according to an estimate by the Bureau of Justice, as you can see, approximately 180,000 United States veterans are in our prisons and jails. Now, as I was typing this out on the slide, all of a sudden it occurred to me that I bet this data is only from those veterans who are enrolled. So I quickly sent a message to Dr. Shreve, and he confirmed that that probably was so, but the answer was a lot more complex than that. So I just want you to know this. This is not, this number probably is a lot larger than that. And that, next slide, please, Catherine. When I started working at the prison, nothing that works on the outside works the same way on the inside. And as I looked more into veterans who were in the prison system, the data for them was, and there is a lot of it, and there's a lot of literature now, or a lot more, on incarceration and PTSD. But in my class alone, 80% of the men in my classes over 19 years had PTSD. Every veteran in my class had PTSD. And there's a high incidence of those diseases typically associated with aging, because in the prison environment, the immune system is bombarded almost daily. And the level of health care that these folks receive is not the same as on the outside for veterans in a veteran facility. I just want you to keep that in mind as we go along. The rates of PTSD and exposure to violence among inmates are much higher than in the general population. And a lot of people didn't come into the prison with PTSD, but they usually walk out the doors with PTSD. Next slide, please. In the prison environment, the risks are great, just because day in, day out, there's a constant presence of authority, lots of discipline, and it's very subjective. It's not the same across the board for everyone, depending on who the COs are. There's a general lack of privacy, restricted movement, pat downs, and strip searches. Now just think of that. Just think of that. Because a lot of the men in my class, I've discovered over time, had been sexually abused as children. Many people have sexual abuse in their history as children. And just think of then going into a prison and enduring the routine and how punishment is conducted. But it's not even punishment, because strip searches are the norm when you go to the visit room for a family visit. On the way out, you have to be strip searched. There's a lot of environmental noise and clacking and clanging of doors, and violence, frequent violence. Next slide, please. So all of these are triggers. Now you might say, well, what does that have to do with end-of-life care? Well, it has a lot to do with end-of-life care, because when I started working there in 2000, not only did we start the hospice program, and I'll just touch on that briefly, the way it began, but we also, I became familiar to other men in the prison. And so if they had a friend in the hospice class and they were struggling with something, they would ask permission to see me. And when they found that I was helping some of the men deal with their PTSD in relation to both their caregiving and the patients that they were caring for, more and more men asked permission for a time with me so they could begin to start their own healing process. In the prison, I don't think the Maine State Prison is any different than any other prison. Some are better, some are not so good. The healthcare is often neglected. A lot of the healthcare providers, bless their hearts, they have wonderful people working for them. Don't get me wrong, some wonderful, wonderful, wonderful staff. But the approach that would probably be used on the outside is not necessarily always the approach that's used on the inside, nor is the treatment the same as it would be. And it really doesn't make any difference within the prison confines if you're a veteran or not. There's no exception made for anyone. It's the same across the board. Quality of life, that phrase is not a phrase you ever hear in there. At least it wasn't until we started the hospice program. So just keep in mind that all of these environmental influences and what the men bring with them from their own history into the prison, if they have a long bid, what they call their sentence, many of them will spend years and then die in place in the prison. So all of this is relevant to the discussion today. Prisoners often die alone, or did until the hospice program was started. That is not the case anymore. And families are invited now. When I wrote the policies for the prison, which had to be, of course, approved by the Department of Corrections, I wrote in that families in the last days of their loved one's life, and keep in mind, many of the families hadn't seen them, that they would be allowed to come in and sit vigil with the caregivers. Symptoms often are not addressed and or managed appropriately or like we'd like to see. But now that they have the hospice program in there, they are much more cognizant of addressing those symptoms. And as I say, some of the nurses are just wonderful and work so smoothly with the hospice volunteers, the men in the hospice class. And we've already talked about the next slide, so you can just segue to the next one. No, back to the one that you were just on. Yeah. So I just wanted to touch on this to tell you that this was a challenge to start a hospice program in a facility that had never even considered doing something like this. And it took 7 whole years for me to develop the trust and credibility with the prison administration, and before we could even begin to train any of the men. There's over 1,000 inmates at our state prison, and it's a maximum security facility, as you probably can well imagine. And it's the only, it holds right now, as we speak, the only infirmary in the state. It's an all-male facility, and women would be housed there in the infirmary when needing end-of-life care. So just pause and think about that for a few minutes. Next slide, please. And so I wanted to throw this conversation in there because I just wanted you to know that the first time I went in that prison to begin training the men to be hospice volunteers and assist the staff with care, I really was apprehensive, I guess would be the best word. And I love this little dialogue I had with one of the men in the class. After they went around and introduced themselves to me, one of them, who just spoke right up and said, actually, he said to me, "You're nervous, aren't you?" And I said, "Well, not really." And then I said, "Why do you ask? Why do you think I would be nervous?" And he said, "Well, for goodness sakes, we're the lowest of the low and you're in prison. Of course you're nervous." And then I said, "Well, maybe I am a bit." And then he goes, it was like an I gotcha moment, because he said, "There, I knew it." And then I said, well, why don't you ask me why?" because my apprehension did not come from the fact I was in a prison. It did not come, goodness knows, from the fact that I was sitting with a group of men who were in prison for crimes that they had committed. I was really concerned that these men probably never had anybody in their life that they trusted, or learned at a young age not to trust at all. And so why would they want to give me a chance to work so closely with them to develop a hospice program? Next slide, please. So I decided I had to, which I am anyway, I'm a very non-traditional educator, which annoys a lot of people. But I knew I had to do something different and unique to gain at least initial a segue at least into the beginning of our work together. So it just came to me that we all had a lot more in common than that which separated us. And therefore, that's why I said what I did to them and asked them if they would allow me to make a suggestion. And I just walked right up to the table and I patted the table and I said, okay, gentlemen, I'm going to put my humanity right here and I would invite you to put yours right beside it. And then if you're willing, let's just go forward together and see what we can do. And they were astounded. One guy actually even said, holy cow, nobody's ever talked to us like that. And so that's how we started. Next slide, please. And in my classes, and this is a little bit of information for you just to chew on, 15% of the population at the prison were veterans. 5 became caregivers in our hospice program. And the first 4 patients we cared for together, because I used to do a lot of on-site work with them. I'd go to my day job during the day and then I'd go make sure I sat with the men at least a couple hours on each shift when they were sitting vigil, so I can see their work in real time and do sort of on-the-job training, and they love that. They really love the investment of time. And as I mentioned before, many veterans that were not on hospice sought consultation for PTSD when the word spread that maybe I was not such a bad person to spend some time with. Next slide, please. And as you all know, and I'm sure many of you do this work in your areas, and working in prisons may not be at all something that you don't have any idea about. So I don't want to diminish the work that you're all doing either. But for those of you who have not spent a lot of time with PTSD or moral injury or the issues regarding suicide, we all know that those, all 3 of those are really staggeringly high with the population of veterans. And suicide is something that we all need to be concerned about. And again, you can just dovetail what I'm going to talk about with a prison environment. Always keep that in mind. And these were the emotions, at least the topics, that we spent so much time talking about. Fear, anger, guilt, shame, you can read the list. It goes on and on and on. And a lot of these are PTSD, but it dovetails with moral injury and sometimes segue to suicidal ideation or suicide itself. And the suicide rate at the prisons in our country are very high in general. So I'd just like to tell you a quick story about one gentleman, because really we're a compilation of stories, are we not? And if we don't invest the time to get to know people, we can't get past the behavior that we might see right up front and center, staring at us in the face, and often angrily staring at us in the face. So I had a gentleman in class who I had fought to get into the class, and I thought he had an incredible amount of potential. And when I first did his interview, I said, this gentleman is really has a moral compass and a lot of emotional intelligence. But he had a lot of anger too. And one day in class, these two veterans were having a angry conversation, and which triggered, because I always used to watch for triggers in class, because just because it was a hospice class, it didn't mean that behaviors that occurred on a daily basis wouldn't rise to the surface in our class too. And I used to use, just for your information, I was not at all hesitant about using experiential learning in class to mediate some of these situations. Now you might say, well, that was a risk in a maximum security prison. Why in the world would you want to do that? But the reason I did it is because it was a learning tool. And I wanted the men, because we had already discussed that many of them had never learned how to problem solve in a way that allowed them to disagree without being disagreeable and not use the tools that they had defaulted to over the years, which was violence, to settle their differences. So after a couple of years in the classroom situation that I just started laying out for you, what the two veterans were at odds about pushed a button in this other gentleman. And he went on a rant. And so at the end of class, and I helped them just calm themselves down and mediate it. And believe me, I'm not ridiculous. I wouldn't have taken chances in class. If I thought somebody was going to get hurt or hurt somebody else, I would have done something about it. I would have called the officers in immediately. But that wasn't the case. And intuitively, I knew that. So I thought we had an opportunity here. So after class, I asked this one gentleman whose buttons had been pushed if I could have some time with him for a moment before he went back to his housing unit. And so I just quietly said to him, he said, sure, what do you want to talk about? And I said, well, when class is over, we'll have a discussion for a couple minutes. So I looked at him and I said, you know, I've noticed you have incredible anger. I said, have you ever thought of dealing with maybe some of the pain behind that anger? And boy, he flashed those brown eyes open and he said, never, I will never deal with that. And so I said, well, that may be your choice. And you may not know this because it's too much of a risk for you. But in order for any of us to heal, we have to deal with the pain that's behind some of our behaviors and some of our language. So I said, you better hustle off to your housing unit or you're gonna miscount. So we did. And it was 50-50 if I'd ever hear from him again. And I thought, well, maybe he'll drop out of class. But he didn't do either. In a couple of weeks, he came back and he said to me, do you have time after class for a quick discussion? I said, of course. And so all of a sudden, when we had our couple minutes together, in about 2 or 3 minutes, he just gave forth with a catharsis of words about some of his history. And then he stopped as soon as he started. And I simply looked at him and I said, what I'm going to do is hold this for you until you feel you're ready to do a little more work with this. And that really solidified our working relationship and began gaining trust from him that there were people that would still enjoy working with him and like him. He was filled with shame and filled with guilt and filled with everything imaginable. So that's just one example of someone who segued into becoming one of the most incredible caregivers in the hospice class. And every man in that class has a story, and we don't have time to tell all these stories. But I do just want to quickly share another one with you, and it's very quick. One of the veterans, Vietnam veteran, because as I mentioned to you, all 4 patients that the men cared for at first were Vietnam veterans. And the veteran in my class, one of them, was on shift one day with him. And they used to work in pairs, the men did. And so they'd have each other's backs and they'd keep each other accountable. And then we'd have class time every week for a day to follow up, debrief, have individual consults, and so forth. So this veteran came to class one day and he said, I'd like to speak with you when you have some time. And what he shared with me was that in Vietnam, he said so many veterans never had a chance to say goodbye to anyone in the field. They'd go off in the morning and didn't know if they'd see anybody. I mean, wars like that. My dad was World War II and with a B-17 crew, so I was very familiar with this. And he said, I never said goodbye to any of my buddies that were killed or badly wounded. Most of the time, I didn't even know what happened to them. And he said, by working in hospice, and he had PTSD, as I said, all the veterans in my class did. He said, by working in hospice, this is the first time I've been able to say goodbye to one of my friends. Now, that's pretty powerful. And forgiveness is also an incredible behavior, but it often isn't present because they find it very hard to forgive. So, next slide, Catherine. Moral injury, as you know, morals and the definition thereof is, it's really for all of us assumptions about how things should happen in the world and how people should behave. And as you know, well, in daily life, certainly with veterans, trauma can destroy these assumptions and turn your world inside out and upside down. Dr. Ed Tick does a lot of writing on all these issues as well, and his book War in the Soul is a great book. There's a lot of authors out there and a lot of literature, so please, I hope you make yourself available, make it available to you. Next slide, please. So what was the impact of my work with veterans? And I'll just wrap up with this. Veterans during the hospice program, years that I was privileged to be at the prison, was actually, without exception, some of the most profound work in my life. And the men in my class many of them became some of the finest caregivers that I've worked with. They had such potential to care deeply for another human being. And this time, over all the years I was there, gave them an opportunity to explore that and to find out the person that they really had always wanted to be. And not only did they heal a good deal, they helped the patients with forgiveness and so many other things. Patients that had come in with PTSD. And just think of all the triggers in the infirmary, you know, that would set off personal care for a man or woman in the infirmary receiving care at end of life who had lost their control and relied on others to do it for them. Next slide, please. So with that, I will say goodbye and thank you. And I know it's time for Q&A. And again, I thank everyone for allowing me to be part of this. And thank you, Carol, for the privilege of working with you.
Well, thank you so much, Candace. Again, if you have any questions, continue to keep them coming in. We had a few come through the chat box as well as on the Q&A. Again, all of the handouts and resources that Carol mentioned are available on the We Honor Veterans website. I know Em was kind enough to share those links in the chat box. They are also on our Trauma Informed Care webpage, which is linked to our homepage, or you can also just search trauma in the top right-hand corner in the search bar. I did also want to mention that, as Candace mentioned, Ed Tick does a lot of really powerful work. We actually hosted a webinar with him, I believe it was last summer, and so the recording of that is available on our resources as well. So if you weren't able to join us for that one or haven't heard it in a while, I would highly recommend checking that out also. Okay, so now a couple of questions I just wanted to pose. One came in, do you see some variance in your patients' responses in terms of their patient experiences by their respective war eras?
And who is that? Is that directed to me?
That is directed to you or Carol, whoever would like to answer.
Sure. Carol, why don't you answer from the VA perspective and your perspective, and then I'll provide another dimension to that.
Yes, so the Veteran Experience Center has looked at this question, and there are some variations. I wonder, Scott, if you could comment on this?
Boy, this is a huge question, and I want to try to address kind of what I'll call the more obvious thoughts about this in terms of the World War II hero that comes back to the ticker tape parade, the Korean era veteran, which was largely forgotten, the Vietnam era veteran that might have been spit on returning in a military uniform. And so trying to build on Carol's comments, we wanted to see what were the differences between the different eras from a family perspective. And it was fascinating that out of, oh gosh, it was in the thousands of a sample size of bereaved family members responding back to our program office. We looked through the qualitative comments. So these are the kind of unsolicited comments from family members. And it was validating, and that the family members of all war eras really believed how important recognition of the service was, validation of the service and honoring of that service, things that I, the partners on this call that I suspect you're doing every day still rose to the top, but there was what I would call a smaller subset of Vietnam-era veteran family members who reported things along the lines of, boy, no one ever really got to the core of suffering with my husband or the Vietnam veteran that I'm reporting about, or why didn't the VA address the issues surrounding Agent Orange in more detail? And so I just wanted to share with you, a number of us were really taken aback as to, from a family member perspective, how few Vietnam-era veteran comments there were. And then I just want to close. Now we went back and we looked at the quantitative issues. And what I mean by that is, well, what's the difference of, how are Vietnam-era veterans who died in our VA system different than other war eras? And that's where the findings jumped out, where we found significant surge, if you will, bump up from previous war eras of anxiety and depression and other issues that we just, we thought they might be there to a more significant degree, but it really surprised us. And I'm grateful to work with some researchers who took it a step further, that they even looked at subsequent war eras beyond Vietnam, and a number of those issues like anxiety and depression continued to increase. And my point for this long-winded response here is that I really believe we're all getting to know the uniqueness of caring for veterans, and what we're finding out from the Vietnam era really may be a precursor of things to come in subsequent war eras. And so we need to learn how to address those issues, not only from the veteran perspective, but from the family perspective who's with the veteran. So anyway, I hope I touched on some of the elements of that huge question.
Yeah. I'd like to just make a comment. This is Candace. The different wars or conflicts that the men in the prison presented were all over the map, but I did see distinct differences between the conflicts that they had been deployed to and a lot of their needs and symptoms. And when it came to symptom management, one thing I did was sit down with the staff and help them understand. And at one point, the last warden, before I was no longer at the prison, he was a Vietnam veteran, Iraqi war veteran himself. So you need to know that 50% of the COs that work there are also veterans. So, but you'd think that they might have a modicum of sensitivity to the men that were incarcerated there, but some yes, but many of them absolutely not. But there were distinct differences when the men would come into the infirmary, and an awareness on the part of the staff, I think, was very helpful to them once they realized that different wars presented with different circumstances, which presented with often different healthcare issues and different symptoms. I do want you to know that we teased out a lot of what was specific to different conflicts, and we built separate programs around that too on the outside. Because my work with the VA Medical Center, and Pam Brown, who is on this call, I think, is the VA Hospice and Palliative Care Coordinator there. And she is just terrific. And I couldn't ask for a better contact over there. So we built a ALS collaborative because of the increasing incidence of neurodegenerative diseases that many of the veterans were coming home with from the Gulf War and subsequent conflicts. So I tried to really pay it forward, if you will, and not one and done with, oh, this is a prison hospice program and it's discrete in and of itself. No, no, no. We need to use what we learn, and we need to bring it to the outside. And lots of times I would bring people to the inside so they themselves could meet with these men, professional people, physicians, and so they could learn what they don't know that's relevant to them. And one of the things I love with our grant right now is the entire Maine Primary Care Association has joined us as a partner, which is very exciting to me because there will be a lot of distribution of information from Pam through the VA, and with the contacts that she's made there, who are also, Pam says, very, very, very excited to get involved with us with this initiative. So there's just all kinds of just segues here and connections that we can take and spread in the greater community.
Well, thank you all for those answers. I have a couple more questions. First, though, a comment for Candace that was entered when she was speaking. She just wanted to reiterate something that you said. That was, they never had a chance to say goodbye. And she says, this haunts my father, a Vietnam vet, to this day. Grieve, no time to process the loss. Just keep your head down and keep fighting.
Yep, yep. So what, may I just respond to that, Catherine?
Of course.
Just yeah, from that, and that was just one of many veterans who shared that with me. Sometimes it just takes one comment to open up the doors and give permission for other people, as you know. And what we did with that is start an annual memorial service in the prison, inviting all the general population and all administration and everyone. I remember one of the first ones we did was outside in the summer around a flagpole. And it really gave voice. And I thank the gentleman who had come forth and shared this with me because it just blossomed into something that still exists today there. Maybe not in the style that we did it, but nothing stays the same anyway. But they still take such pride in doing this memorial service. And when possible, still, we did it outside for several years. Even one of the men in my class who was very musical wrote a song and sang the song at one of the services. And we actually put the song on the CD that we cut with another grant that we received. So we try to just make sure this is a dynamic process, that it was continued to pay itself forward, and it just grew and grew and grew. So thank you to whomever made that comment. I so appreciate your feedback, and bless your dad's heart. Thanks.
Okay, so another question for Candace. There was a comment, wow, how amazing. Thank you for sharing this incredible work. In retrospect, what was your greatest challenge or concern when embarking on the work in the prison system?
Oh boy, that's a great question. I love it. Thank you for bringing that up, because by far and wide, when the first day I walked in that prison and people found out why I was there and what I was doing, I could tell who just wanted me to leave because they saw no need for the culture to change in that prison. And actually, there are many comments, some of them laced with language that I wouldn't even be able to put on the screen here. But it didn't deter me one bit. It just gave me, I guess, if you can believe this, even more resolve to do what I was doing. Because that's the problem. If you've read much history about incarceration and the evolution of it, and then tag that with someone like veterans who are dealing with PTSD, trying to survive in there. And Maine is better than a lot of places for sure. And they've got some great people, administration, some great officers. But, you know, as we have heard recently, we need to teach people how to be guardians and not warriors all the time. And so there were people that wanted me to leave. So by far and wide, it were some of the officers that I knew in the end would probably get their way. And one of the wardens did say to me, he said, Candace, as long as you're here, I myself will protect you and protect the program. But he says, I've got to tell you, and I'll tell you right now, that when I leave, because he was getting ready to retire soon, he said, I can't promise a thing. So I knew all that. It didn't deter me. You know, we all do what we can do as long as it's needed and as long as we can do it. So if you go into things with that attitude, you know, you'll be okay.
Okay, we have another question for Candace. How has the coronavirus epidemic affected the program, and are you still using volunteers?
Well, as I think I touched on, I was there for 19 years and I'm no longer there because they did get their way. But the men all stay in touch with me, and I'm still working with some of them with their PTSD. They write letters, I call, and it's just wonderful. I think they sort of see me as a touchstone. Some of them call me mom, and it's really quite dear. So the coronavirus, I understand what has happened there. Oh, number one, all the classes I did, the weekly classes and the one-on-one time with them. Sometimes we'd schedule an hour together, and you can imagine how much time it took. But there again, I think the wellness of any individual is dependent on how much time society wants to invest in them. And so we all do what we want to do, and that's exactly what I wanted to do. So they don't do any of the weekly classes anymore, and it's just purely in the infirmary assisting the staff, but for 4 months now that they haven't even been able to do that. And they haven't been able to sit vigil with men who are dying, which breaks their hearts. There's a gentleman, his name is Stevie, and in size, a small stature, but wiry as all get out. And one of the men he was caring for was a Vietnam veteran, and he, at the end of his life, toward the end of his life, he started screaming. He was trying to fall asleep, and all of a sudden he started screaming. Now, in the prison, you know, the rules of the road are you don't touch anybody. And officers that were against the hospice program in the first place, if they were on duty and saw something like that, even though the staff wanted the men to do what they needed to do, it just was a conflict right there. So Stevie, who was passionate about hospice work, passionate about people dying, not dying alone, passionate about people dying with some quality of life, when this gentleman started screaming that he was drowning, and this is a favorite story of all the men, and if you saw him, he's probably only about 5'6", but I say wiry as all get out. But you find the energy, right? We all do, to do what we want to do. And he just went up to the bed and put his arms around this fellow, who was a big man, and just held him. And I mean, the gentleman who was the patient was saying, you know, they're going to get me, they're drowning me, and he just went on. And Stevie just and this gentleman whose name is Stevie, if you knew him, he didn't say 2 words when he entered the hospice class. God love his soul. He was quiet as a mouse. And then he just came, eventually, I'm really intrigued by people who are very introverted, and because there's always a reason for it. And so I helped I said, Stevie, you tease out that person in there that you really want to be. And so we worked together a lot, one-on-one. And the other guy was probably twice as big as Stevie was. And Stevie held on to him and just quietly talked to him until he fell asleep.
Mm.
So those were the conflicts and challenges. But really, there was just I think the men actually, despite themselves, they just surprised themselves so much. They knew that inside they could all become. And that's so funny, because some of the other academic instructors in there that were teaching college courses, one of them came to me one day and he said, I got to ask you a question. I said, what's that? He goes, I have some of the men in your class in my class. And I said, I know, that's great. I think there should be more overlap. And he goes, but I got to ask you, how come a lot of them use some of the same phrases? And I chuckled and I said, and what might be one of those? And he goes, well, one of them they seem to really think is important is presence. And I said, well, if you were in our classes, you would understand that presence means either success in a relationship, presence in the way of listening and listening intently, and when it comes to caregiving, a caregiver who is present for a patient as opposed to caught up with their own agenda makes all the difference in the world to the trust a patient gives him. So yes, there were lots of challenges, but there's so much beauty in the work we did together. And the coronavirus has made some of the men bereft because they can't be with the people that they really want to be with. And Stevie talks to me about that all the time.
Well, I think I echo all of the attendees when I say thank you for sharing not only that, but the other stories that you gave to us throughout the presentation.
Oh, you're welcome.
There were no other questions from the chat box or Q&A came in, but I had one for the presenters, Candace and Dr. Loers, and even Dr. Shreve, if you would like to answer. If there were one takeaway or one thing that you would like hospice staff or volunteers to keep in mind when they're entering the space of someone who had experienced trauma or who is a veteran, what would that be?
Go Candace and Carol, and I want to try to have time to think of a really good answer, but I have an idea.
Well, I've been talking for a while, so I'll catch my breath, Carol, and you can have the floor.
That leaves Carol.
I'll go first. This is Scott, and I'm not sure of a really pithy answer to get to it, but I just have this sense that so many of us in hospice want to help people kind of in their journey and moving forward. And my sense is that sometimes it's really better to just be present and not try to guide the therapy, not try to force someone to move forward, and not try to be too intrusive in our questions about the past. And so I guess I'm left with, if I had one thing to say, it would be to be present.
The guys in my class would be proud of you, Scott.
I need to take your class, but I hope I don't get there in a different way.
You can come as a guest, or you could come as a guest, yeah.
Okay.
I'll jump in, Carol, if you want a couple minutes to think about it. Carol? Well, I'll just jump in anyway then, I guess. I think there's number one, I wish everybody could meet the men that were in my hospice class because they are bright, they are emotionally intelligent, and believe it or not, even though they're residing in a correctional facility, many of them have incredible emotional intelligence. And we spent a lot of time talking about that. Now, as far as a takeaway to the outside and to general population, I think there's a lot of lessons about trust that I hope you, even the little in the beginning, that little conversation I shared with you, and the fact that all of us do have more in common than that which separates us. And I think if we approach people with that in mind and invested time, I said to the medical association a few years ago, I was asked to do a presentation, and I just shared at the end, it just popped into my mind, that maybe the enemy of well-being in our society is our unwillingness to invest time in people. And going into the prison for me, I knew right out of the gate that I shouldn't be there if I wasn't willing to invest time. And especially when I met these remarkable men. And I doubt if our program in particular, the way we structured it, because the dimension of it was about rehabilitation for me. And I think everything we need to do with an element of appreciation that people have histories, they have stories. As I started out, I said, a compilation of stories. We all are, whether we want to think about it or not that way. And I think if we could invest time, and I know everybody's saying to me that's not how our model of healthcare works in the general population, and I appreciate that, believe me, I do. But I also think that that's what's desperately missing is the element of time, the presence for one another, the trust that's developed, and the work, and it is hard work, that the men are doing, and that all patients who are dealing with end of life, it's their work to do. And I think if we just put ourselves on a level playing field and don't think that we have the answers to anything, that we want to learn as much as we can about them. So, yeah.
And hi, just one final couple of words. This is Carol. Sorry, Candace, I couldn't get myself off mute in time. I think what Candace has so beautifully illustrated is that we need to approach this with humility and knowing that we don't have all the answers, listening, respecting what the patient's experiences and what the family's experiences. And I think the brief practice guide on PTSD points out a good practice would be to listen to the family because they know the patient the best and they can tell you what's helpful and what's not helpful. One size doesn't fit all with this, and it's really a challenge to offer the very best care to these patients.
Okay, I know we're right at the end, a couple minutes, but that's okay, over our time. But I just wanted to give our panelists one more chance. Were there any other closing words or final thoughts that you wanted to share before we wrap up?
I'd just like to say thank you all for taking the time to be here with us today, but also if you haven't found yourselves reaching out to disenfranchised and underserved populations of all kinds, you're missing a great deal of richness in life.
Mm. Thank you for that, Candace. I have nothing else to say. Thank you all for being here, for spending your time with us. Again, everything that we spoke about, the different brief practice guides on PTSD and emotional support prior to death, as well as the PowerPoint slides for this webinar are already up on the Trauma Informed Care page of the We Honor Veterans website. If you have any other questions, thoughts to share, please reach out to us, veterans@nhpco.org. But otherwise, stay tuned. We will have many more resources and hopefully webinars and opportunities to get together and share our experiences coming in the near future. So thank you all again, and a big thank you to our panelists for their time and expertise as well. We really do appreciate it, and we can see from the chat box everyone's excitement and gratitude as well. So thank you all. Have a good afternoon.
Thank you so much. Bye-bye.
Bye.
Yeah.